Oh, thank you very much for allowing me to talk. Coming from the UK, where the guidelines are actually similar to the AHA guidelines as well, but we make a stronger distinction between medical patients and stroke patients. So you've got VTE prevention guidelines for stroke, for medical patients, and the stroke guidelines, which supersede those. And these are by the NICE that intermittent pneumatic compression should be used for all stroke patients who are immobile unless there's a contraindication. These should be used for 30 days or until the patient is discharged and mobile. And we should not offer anti-embolism stockings, and we should not give prophylactic anticoagulation. This is actually the same as the AHA guidelines for stroke, but not the same as the medical guidelines. And that is because the risks are different in our stroke patients, and there is different evidence for them. This is a very busy slide, and I'm sorry but I'll try and summarize it for you. What we're looking in this large meta-analysis of more than 16,000 patients and 15 trials is to compare prophylactic anticoagulation in stroke patient against no prophylactic anticoagulation, and looking at the risk of symptomatic venous thrombosis on the left towards symptomatic brain hemorrhage on the right. And what it shows is, the top one is low molecular heparin. It shows that all forms of prophylactic anticoagulation effectively reduce VTE. There is no doubt they reduce VTE. But at the same time, they also effectively cause hemorrhages. And depending on what type of anticoagulation you use, it is up to 2.5 times. The risk of a symptomatic brain bleed is 2.5 times as the risk of as prevention of a symptomatic VTE. So it's not worth it, because although you're preventing it, you're causing extra trouble. And that is what has driven the UK guidelines against prophylactic anticoagulation, and the AHA guidelines also against prophylactic anticoagulation. I think in the UK, the first response to this recommendation is, yes, but there are these patients who've got really high risk of VTE, and we've got to treat those. So the authors of the largest studies of VTE prevention for the intermittent compression stockings and the previous CLOTS 1 and 2 studies for the graduated compression stockings, they've done an analysis looking at risk factors. In their CLOTS 1 study of 2,500 patients, they tested all the risks. There were 12 individual risk factors for VTE, and they narrowed them down to 4 important ones, which were most predictive. They put them in the model and tested it in the second data set, which was over 3,000 patients, and found that none of them reliably predicted whether the patient was more at risk of VTE than somebody else. Part of the problem is that the patients who are at risk of VTE are also at risk of hemorrhagic transformation. So we cannot predict patients who are more likely than others after a stroke to get the PE. So based on that, as I say, we use IPC compressive treatment as the first choice, but not every patient can tolerate it. In the CLOTS 3 study, which established this treatment, 1/3 of patients didn't actually tolerate the intermittent compression. And some have got contraindications. That's peripheral vascular disease, leg ulcers, risk of falls, restlessness or agitation being the main factors. So what we were looking at whether there was anything else we could do. And as I say, my colleagues asked me, can't we give chemical prophylaxis? Can't we give anticoagulation? But the argument is, no, we cannot. So we were looking for something else. And at the time, this new device has been approved for potential use by NICE, and it's an electrical stimulation of the peroneal nerve, which causes twitching of the leg, like that. If you do it, if you have it on high power. For VTE prophylaxis, you don't actually have to see the twitching, but that's what it does. It makes the leg twitch, it activates the leg pumps, it increases blood flow in the superficial venous system and the arterial system. And as I say, it's been approved in 2016 for use when when compressive treatments are not indicated and any other treatments are not indicated either. The FDA has just cleared it in last year for the same indications. So we developed a new pathway where every patient who needed prophylaxis was given mechanical prophylaxis, and every patient who needed it was defined as being immobile. That meant that they couldn't walk without help. So some of them were flat in bed, others just needed a nurse to help them with. If IPC was not tolerated or not contraindicated, we used the electrical stimulation via the geko device. The nurses checked 4 hourly, they do comfort rounds, make sure the patient doesn't want to eat, drink, go to the toilet, and at the same time they checked that these devices were in place, and there was a daily nurse-led VTE round as well to make sure that everything is done properly. So that's a new pathway, a combination of a new device and more active surveillance that everything is given as indicated. We audited it, so over the last 2 years, a prospective audit, over 1,300 patients. The ward where it's been done is a 29-bed acute stroke unit in a large university hospital. We met over 1,200 strokes in a year, and we're a primary stroke center providing thrombolysis and mechanical thrombectomy. So one of the major stroke units in the UK. Every patient was included in the audit, apart from those where VTE prevention was not appropriate, i.e. patients who are already palliative, or we also included the ones who were transferred to other centers because we couldn't follow up their VTE prevention. The patients we found were, like all stroke patients, mean age 75 years, about half males and females, majority ischemic strokes, a few hemorrhagic strokes. So VTE prevention, which you can see here, grey is IPC use. So you see the majority got IPCs primarily. The 7.1% above is the ones who didn't tolerate IPC and were then changed over to geko. The blue ones are the gekos primarily, mainly in patients where we worried about mobility. They were partially mobile but not fully immobile, and we were worried they get out of bed and fall over the IPC device. 19% didn't need prophylaxis because they were well enough and were going to go home. 11% were fully got chemical prophylaxis. They were fully anticoagulated, so they didn't need IPC either. And 1.5% refused any form of prophylaxis. So that's our patient group. Of those who required gekos, 2/3 got it because there was an immediate contraindication, and 1/3 got it because they were intolerant of the IPCs. This is probably the most important slide here, and sorry for it being a little bit messy, but the overall incidence of VTE in our unit is 1.5%, which is considerably lower than most centres, and I think considerably lower in the UK. So although we don't have any chemical prophylaxis, we still have a very low rate. Amongst the first column, the ones who had IPC alone, compression treatment alone, the incidence of VTE was just below 2.5%. In the 316 patients who got geko, either as first choice or in a switch, the VTE incidence was 1%, pretty similar to those who got pharmacological prophylaxis, and that is entirely full anticoagulation. So not just prophylactic, because the ones who got pharmacological usually got it because they needed full anticoagulation for atrial fibrillation. The ones who refused prophylaxis had, as expected, high incidence, 4.5% of VTE, which you would expect in this population. And even those where prophylaxis was deemed unnecessary still had a significant incidence of VTE. This is just looking at tolerance of the geko, the compression device in the first column versus tolerance of the geko, and more patients tolerated the geko. This slide is a summary slide at an earlier stage of our audit. That's what we've done when we had the first 1,000 patients enrolled. Before the geko, before we had the new pathway, the first 1,000 patients, incidence of VTE was 2.8%. When we introduced the new pathway, including the gekos, our incidence of VTE went down to 1.5%. As I said, it's a very low incidence, and it's a low incidence achieved without prophylactic anticoagulation. So in conclusion, the new pathway, including the geko, was associated with a very low VTE rates without anticoagulation. The geko device was well tolerated, and nursing staff found the device easy to use. This change in clinical practice is now embedded within our institution. It sounds very positive, but we've got to remember that these are audit data, and audit data are not necessarily clinical trial data, but it's based on as much evidence as we have. So we are not planning to replace IPCs, because compression treatment is the evidence-based treatment. And where it can be given, we should be giving compression treatment. That's evidence-based, strong evidence. But where we cannot use the compression devices, we have to look for alternatives, and that's where the geko device would come in stroke patients.